That was outstanding. Our next speaker is well-known to all of us, Pat McCarthy, who has put a tremendous amount of thought into this and, to the benefit of all of us, has quantified many aspects of mitral valve repair. Pat.
You didn't walk off with the remote, did you? Oh, here it is. Well, like all of you, we have mentors in our career, many of which that we spent time with, training with, and Jim Cox is here, Norm Shumway comes to mind, and many others. But we also have mentors that we just know from the podium or that we've gotten to know, and Tirone is certainly one of my mentors that way, kind of a mentor from afar. And I will tell you right now, Tirone, you'll be happy to know this afternoon, I'm with you. We don't need to repair that many tricuspids, so you get my vote. You're going to win with that one. So they asked me to talk about how I do this, so I'm going to go through my technique about how I approach mitral valve repair. A lot of it is based upon, these are my disclosures, upon Professor Carpentier's initial concepts, and I've actually tried to think about how to sort of refine those and actually make those more a little bit mathematical and try to make it so that others can apply these more often. So number one to me is to get a coaptation length of 5 to 10 millimeters. Less than that, you're at risk for residual or recurrent MR. More than that, you're going to be at risk for systolic anterior motion. We just did a study with our echo people, and in the last 186 repairs, we actually hit 100% within that. No residual prolapse or restriction, so the valve is going to close at the proper height. And if you do that, then you're not going to have any MR at the end, and you also won't have any systolic anterior motion. So step one is the measuring twice. So intraoperative echo on the bottom right, the first thing they know when I walk in the room is they'll tell me the length of A2. Scanlon makes those pickups that you look at in the top right, and for about 15 or more years, I've been using that, and I also measure that directly. And so with that, you're going to be able to see exactly what the numbers are. And on the bottom left is what was kind of average out of a series of about 1,000 of mitral repairs, normal being A2 about 22, and most of the degenerative MR is enlarged. So step two is reconstruct the posterior leaflet. I'm a resection guy, so I reestablished a 2-to-1 ratio of the anterior to posterior leaflet. A simple repair is you do the resection, both sides are 14 millimeters, you just put them back together. On the bottom, I'm showing a measured partial foldoplasty, which is much more common. I do that in about 70%. I actually haven't done a real sliding plasty, maybe one in the last 10 or more years. And again, it takes about 10 seconds with the calipers to get an idea about the numbers. So I'm not eyeballing it. I'm not saying that's too tall, that's too short. I think it's about this. I actually kind of measure that. It's a little nerdy, but it actually works. When you do that, then how do you size the ring? So a lot of discussion about this. I don't use a sizer. I haven't in many years. You don't look at commissure to commissure. Professor Carpentier came up with that way back in the early 70s, but it's really not relevant. The valve doesn't close commissure to commissure. It closes anterior to posterior, not trigone to trigone area. Craig Miller called this voodoo as we're doing the sizing. What I do is that I want to know what is the height of the anterior leaflet, and then I want to know the AP distance of the ring that I'm going to put in. And you do a little simple math. It's in a paper that we'll refer to later, and that will give you the right amount of coaptation. If you do that, you can avoid SAM. So in the last 1,100 or more now patients, 0.3% SAM in this group of patients. A second number they tell me when I walk in is the coaptation point to the septum. If you think of Hokum patients, the septum pushes over and it gets to be very short. If you have big leaflet and if you put a small ring in there, or if you leave the posterior leaflet too tall, can you back up? For some reason this is advancing on its own. But if you put in went a little too far back. So if you have a tall posterior leaflet, it pushes it towards the septum. The magic number is 25. So you don't want, if you had 25 or less, you're going to be at risk for SAM. If you're something like 30 or plus, you should have a very low risk for systolic anterior motion. The coaptation length is going to determine the SAM and also the durability, and I'm just showing the different size rings. If you look at the AP diameter of a 38 versus a 32 ring, it just shortens it by 6 millimeters. All that's going to do is change the amount of coaptation that you get. And so people perseverate around whether it's a 34 or a 36 ring and all. The AP diameter isn't very much different. So again, these are the same concepts. We're just putting a little bit of math to it so that you can understand it a little bit better. And the final point I wanted to make is that I close the clefts. I don't want any small residual little jet through the leaflet. I don't want the echocardiographers to have anything to look at. And the other is that when you put the leaflet back together, you may leave a little ridge there. It's a little bit lumpy. And when the anterior leaflet hits the posterior leaflet, you want that coaptation surface to be smooth. So at the end of the operation, I'll throw in a few other sutures to help smooth that surface. So the video is going to be a 27-year-old woman I operated on a couple of months ago. I had actually operated on her mom about 3.5 years before this, and they had the almost exact same pathology. She'd known about degenerative MR for 6 years. She was being followed by her cardiologist in New York with, quote, watchful waiting. Unfortunately, he watched a long time. She showed up in Chicago with the usual sort of symptoms, but also her EF had dropped to 53% and her LV was dilated. She had bileaflet prolapse, multiple jets, trivial TR, no AF. And this is the pre-op echo, and it just shows bileaflet prolapse. So this is the pre-op, intra-op measurements. This is looking at the C-septum, which was quite large at 3.8, so she's not going to have any significant risk for SAM. And then also the measurement for the AP diameter is, I think that's 3 centimeters or 30 millimeters. So that's kind of typical for this kind of patient. First step, what I'm going to do is that's the calipers that I'm measuring the height of the A2. As I said, this only takes a moment. Then what I'm doing is that I've identified normal chords on the anterior leaflet on A2 and at A1 and A3, and now I'm doing a resection of the bileaflet prolapse. This is showing I do a resection that is not the old quadrangular resection. I go down to reduce the height, and then I kind of bring it together towards the end. This is kind of a smaller at the base, maybe than what we're looking at this. What I'm trying to show here, apologize for the camera, which is going to be replaced in June, but you have to trim that segment. There's normal chords almost always in those patients. I saw David cut a lot of those out on his patients, all those normal mid-body chords on the posterior leaflet. But you trim the leaflet down until it's just cord tissue with a little bit of adjacent, and then I usually use 2 sutures on either side to orient it properly, and then I bring it up from the posterior to the anterior leaflet with that. This is actually pretty simple. Toby Cosgrove showed me how to do this in drawing in about 5 minutes in his office one morning, and I'd never even seen it. Then you just fill in the space between those 2 sutures. It's usually 2, maybe 3 figure of 8 sutures. I use 5-O-ethibond to do this, just left over from my training at the Cleveland Clinic. And then at the end, it's a little bit of free edge remodeling. When you put this there, you may end up with a little bit of a dog ear on either side, so you want to get rid of any of those areas that just have that sort of irregularity. So now the P2 to A2 has been transferred. Now I'm going to do the reconstruction of the posterior leaflet. Do that after you do the cord transfer. It's easier to see the cord transfer if you haven't already done the posterior leaflet. And so this is showing a foldoplasty on the left side here towards P1. I didn't have to on the other side. And so this is still a remnant of P2 that is lateral is quite tall, and this is just showing that I'm going to fold that down. I know the numbers, and I had looked at them on this. P1 and P3 were roughly normal size, so I didn't have to do anything particularly important to those. I put those together in 2 layers, and then now what I'm going to do is I'm going to look for the little sort of clefts, the P2, P3 cleft, the P1, P2 cleft, and as I'm doing that, I'm going to close the clefts, and again, I'm going to sort of smooth that surface to make sure that the anterior leaflet isn't hitting against anything that is going to leave a little jet, as it would show up on echo. This is after you've done the majority of resection. This usually takes about 5 minutes. As I'm doing this, I'm making sure that I am getting all the way to the chords on both sides. After the repair, it's a nice symmetrical repair. This is what it looks like after you have your ring in there. This was following it, and I have them measure the coaptation length. Like I say, we shoot 100% for 5 to 10 millimeters. In this patient, they measured 9 millimeters. If we did the calculations, knowing the AP diameter, et cetera, we came out with an expected coaptation length of 8.5 millimeters. They measured 9. They should check their echo, make sure it's okay. So the operation was a trapezoid resection, measured folding plasty, which we made 13 millimeters, chord transfer, cleft closures, the new transform ring. So here is the post-op echo, which we already saw. These are the results. This is the algorithm paper I mentioned. During the 2 weeks of lockdown during COVID, my residents and visitors have been after me to write this up, and so that's what I did for 2 weeks. So 30-day results, 0.2% mortality, SAM 0.3%, 10-year results, freedom from reoperation, 99.7%, and then failure rate, if you include the patients didn't have a reintervention, but that had significant residual mitral or recurrent mitral regurgitation. And then one of my residents, Sarah Nisavaco, presented this at AATS a couple of years ago. So this is looking at the anterior leaflet. So having learned about chord transfer from Carpentier, and then seeing a lot of early failures with neochords, I stayed away from it. And just this week, my partner had a patient transferred from Vegas with a failed after neochords 1 month later that needed a reoperation. So looking at these variety of techniques, 10-year results, chord transfer 99%. Commissuroplasty is in complex patients that have multiple different treatments. Edge to edge with a ring, and then ring plus resection if there's only a mild amount of prolapse. Those actually both did well. So we're trying to take this essentially from an art where some of these reops look like a Picasso and make it more of a science. And we do that now in TAVR, and we do that in aortic valve repair with measurements, and also we can do that with mitral valve repair as well, where we can make it so that you can predict you're going to have a coaptation length of 8.5. They're going to measure 9 millimeters, and I think that's where we ought to be heading with it. Thank you.
Okay, so we're going to move on to the, I guess, the contrasting talk on artificial neochords by Michael Chu.